building blocks and terminology that I'll be going throughout the rest of the course. So this is really important stuff, and it'll come up time and time again. It's how we talk about, it's all the foundations behind why we renally adjust things and why we worry about drug interactions, really, when it comes down to it. Okay, so let's talk about some drug definitions. A drug affects a biological system. Poisons and toxins are defined there. We'll do a toxicology lecture in the summer specifically to talk about toxins a little bit more. But a drug could be a toxin. Toxins depend on how much you give somebody, really. So pharmacodynamics as a definition is really simply what drugs do to your body. And there's really kind of some basic concepts here that I think are important. And again, we'll come back to a lot of this terminology throughout the course. So receptors. So most drugs interact with some kind of a receptor. And they're going to interact as far as being an agonist or an antagonist. An agonist elicits a pharmacologic response, which means that it's working with the receptor and causing something to happen. An antagonist is classically something that's going to bind to a receptor and not activate it at all. However, there are differences within these terms. So for example, within agonists, you have partial agonists that produce a pharmacologic response, but not fully, and may compete with other agonists. So a good example of this is a drug called buprenorphine, or has anybody heard of Suboxone? It's used for opioid addiction. So that's a partial agonist for the mu-opioid receptors. And what it does is it binds to the receptor and activates it a little bit. So you get a little bit of an opioid effect from the drug, but not as substantial as you'd get like if you shot up heroin. But if you do happen to shoot up heroin while you're on the drug, it's going to compete with heroin. It binds tighter than heroin. So your heroin won't have the same capability to stimulate those receptors as it would without the drug on. So it's got a twofold effect there, which is why it's pretty effective medication as far as what we have for opioid abuse and people who have struggled with that in the past. So that's a good example of that kind. Antagonists have some more layers with them. So again, the classic antagonist binds to a receptor and blocks anything from happening. So I think like a beta blocker. Beta blockers bind to the beta-1 receptors in the heart. They prevent your endogenous chemical signaling method from happening. So you can't get your adrenaline response to kick your heart into gear. So people who have chronic stress going on in their cardiovascular system usually have circulating norepinephrine and epinephrine floating around that's causing vasoconstriction. It's causing the heart to work harder than it needs to. And ultimately what happens is if you block that process from working on the heart, it can't interact with those receptors, so your heart rate doesn't stay as high, your blood pressure goes down, you decrease your heart's work. That's kind of the basics behind how a blocker would work. So you have some system in the body that's working too much and you want to stop it from doing that. That's really what the idea is there. Competitive versus non-competitive. Some antagonists bind directly at the same site as our endogenous mediators do. Others might bind to a different site on the receptor and cause a functional change in the receptor so that drug can't, or so that the endogenous target can't bind to the drug anymore. Reversible versus irreversible. Some of them will bind to the receptor for the receptor's life. Receptors degrade and get rebuilt just like anything in our body does. Just the cells recycle as well. But it'll bind to the for the duration of its life. Irreversible means that it binds and then it eventually, or sorry, I'm flipping that, right? Irreversible binds and degrades. Reversible means it'll bind and it'll detach at some point. So it kind of has an equilibrium with its affinity to the receptor. It doesn't really matter from a clinical perspective, so don't get too bogged down. Just know that there are differences there. Some people think reversible means it's stronger or better clinically, but sometimes it's the opposite of that too, so it doesn't really matter. I'm just pointing it out to show the differences here. And then there's the concept of a functional antagonist. A functional antagonist means it doesn't do anything to the receptor, but when you give the drug, it does something in the body that antagonizes a certain physiologic response. So sometimes we'll use that term, and it's important not to get those two confused because it's not doing anything, again, to the receptor. It's just causing an effect that's different from what the endogenous effect would be. Dirty versus silver bullet. I'll use the term dirty drug occasionally. Dirty drug means it hits a lot of different receptors at once. I think about a good example would be antipsychotics in the brain. They work on a ton of different receptors and systems, whereas like a beta blocker works on kind of one or two systems and can be selective for one system. All right, I've used the term affinity a couple times today. Affinity is the tendency of a drug to bind to receptor. Higher affinity, tighter binding. Potency, different drugs, different types of bonding. So potency all has to do with how that drug binds to the receptor and how it interacts, which can have to do with affinity too. So something that has high affinity might have a bit higher potency, but they are different as far as their terminology. You can have them exclusive of each other as well. But potency doesn't really matter all that much. It's all about the dose we give. So we can have two drugs in the same class, one that's really potent, one that's low potency. We just dose them differently. One we might give 10 milligrams a day of, the other we might give 100 milligrams a day of. We just compensate for that. So it doesn't necessarily mean that it's a less clinically effective solution is what I'm getting at. However, you do have differences there that could potentially lead you towards one therapy or another. Like maybe if somebody is trying, an example would be there's a medication called Keppra or levetiracetam used for epilepsy. And a new drug came out, which made by the same company, called brivaracetam or Breviact, and it's a more potent version of Keppra, really. But for people who have irretractable seizures, it's actually been working better than some of the other drugs we have. So sometimes the potency is enough to get people over the hump if they aren't responding to their therapy. So sometimes that is beneficial, but generally speaking, we just dose adjust to make it up. Efficacy, just can it produce the biologic effect you need? May or may not be related to the potency or the affinity. Again, this gets a little complicated, kind of confusing. The point is that you have an efficacious drug that works clinically. That's all we care about in this class for the most part. Does it work clinically? Do the guidelines say it's good? Do we have evidence to support that this drug gives us the physiologic effect we want? The science is great, and we want to understand that too. We don't really care how much affinity it has for a binder, except in certain subsets. Again, buprenorphine is a good example. Higher affinity than heroin, higher affinity than oxycodone, higher affinity than most opioids out there. So if you're abusing opioids, buprenorphine is a drug that will have more affinity for the receptor to bind it, and it'll compete be more competitive in that situation. So sometimes it matters. Again, most of the time it doesn't really. Specificity versus selectivity. Highly specific drugs will bind to one type of a receptor. Highly selective drugs will act in one place of the body. So kind of what I was talking about, the ideal drug would be highly specific and selective. Most of the time we can't get that. Occasionally, there are some examples out there. Like we have some drugs that are work on muscarinic receptors and are anticholinergic, which if you give that to somebody and affect all their cholinergic receptors or muscarinic receptors in the body, it can cause a lot of significant side effects, dry mouth, constipation, urinary retention. However, if you focus it just on the receptors in the bladder and on those subtypes, you can help with urinary spastic issues while avoiding all the systemic side effects. So we do have some drugs that are highly specific and highly selective. Agonists. So just another discussion on agonists. Again, what a partial agonist does, it really kind of reaches a maximum activity. It doesn't really get above that. And that's usually due to the way it's interacting with the receptor. It might have some sort of a it might be binding slightly to a different site on the receptor, or it just might not be, it might be kind of having a reversible, irreversible effect on it where it's bouncing in and out as it reaches equilibrium. But for whatever reason, the partial agonists don't reach that full activity level of a full agonist. These are, by the way, I should show you what I'm talking about here before I keep going. What this, sorry, my thing's going crazy here. There we go. What this graph is concentration and activity. So usually we look at response versus how much drug's in the body. So activity could be a percentage of, let's say, beta receptors getting blocked, or I don't know, beta receptors getting agonized, whatever it might be. That's your activity percentage, and this is how concentrated you have to get. Generally speaking, the more drug in the body, the better the response. And at some point, you kind of reach a threshold where you only get so much response. So we'll come back to that concept here in a second. Antagonists. So an antagonist is a little bit different, but it works kind of the same way. These are logarithmic scales, which is why they look a little bit different than the other graph. But the idea is the same. So you have dose and the percentage of maximum effect here overall. Again, this is a very simplified model and way to look at it. But what you have is an agonist alone. So let's say you give the drug of an agonist, and then you put the antagonist on. You're going to push this line further down. So let's say your agonist in this case is norepinephrine interacting with beta-1 receptors in the heart, increasing heart rate. You give metoprolol, which is a beta blocker, you're going to block the effect of that agonist, meaning that your body's going to have to kick out this much more dose of the agonist to be able to overcome that drug that you just gave. In a lot of cases, the body can't do that, or it's going to overtax itself. So you can reach that equilibrium without having to worry about that. Now, if you're giving somebody drugs or something, that's different. But and yeah, like if we go back to the heroin example, if you dump a bunch of heroin into somebody's system, you can overcome some of the effects of that partial agonist effect. But at the same time, you are blocking the ability of the body to make more, to make enough to really overcome that, and that's the idea behind the drug. Agonist alone, plus irreversible antagonists. I'm not really concerned you know that versus irreversible versus not. I don't really care about that. This gets a little bit more confusing. Again, the receptor binding science behind irreversible and reversible, it's just not really all that clinically relevant. So it's there as a reference. And again, the book, if you really want to get into this, the book does go into a bit more detail than I am today, but we'll leave it at that for there. What I'm really concerned with from an exam perspective is that you understand the basic concepts. So if I talk about agonists and antagonists, do you know generally what that means? Do you know what it means to be a partial agonist? Do you know what transmembrane signaling means? So some of these big concepts that we're talking about today. The questions from this lecture are pretty general, I would say. So it's an overview. I'm not trying to get into the nitty-gritty, but I'm trying to show you some of the nitty-gritty details so that you have a better understanding of it. All right, so receptors and how they work, generally speaking. So we have, this is a dopamine receptor here. Dopamine can be used in a lot of different situations. We manipulate it for the purposes of blood pressure, for the purposes of nausea and vomiting, for the purposes of mental health. And so they're all over in the body, but here's a dopamine receptor as an example. And this is what's called a G protein coupled receptor. So when you have dopamine in the body that works, interacts with this receptor, in this case it's the natural agonist of the receptor, this system releases a protein or synthesizes a protein, so it has a downstream effect and interacts with a couple other different systems. So adenylyl cyclase, protein kinase C, start doing some things with ATP and energy, and all the cell cycles start to work together, and ultimately you open up a channel. And that sodium channel opens up and causes some sort of an action potential, or the ability to have an action potential. And that's generally the concept behind a lot of the receptors that we're interacting with. So we're either blocking this process from happening, or we're making this process happen, depending on what types of effects we want. So G protein coupled receptors are probably the most common type of receptor drug target that we'll talk about as far as this bulk of medications when we talk about receptors. Now, do we need to know that all this is happening in the cell to be good clinicians? No. We just need to know from point A to point B, but this is all the middle ground stuff that actually does happen. So when we talk about anti-epileptic drugs, and I say they block sodium channels from opening. Well, what that does is it means that it decreases the brain's ability to fire because it can't repolarize as quickly as it does, so you can decrease the ability to have seizures that way because you're decreasing those excitatory responses. And we block receptors to do that. Or we could agonize the receptors and cause a seizure, which we don't want to do, but you get the point. So anyway, this is the idea behind the transmembrane signaling process. Just interacting with the receptor, making proteins, causing a downstream effect in the cell, eventually opens a channel and changes the electrical signaling system that your body uses naturally. Ligand-gated ion channels are a little bit different, but it's essentially the same concept. So instead of going through that roundabout G protein process, you're just interacting directly with that sodium channel, or whatever channel it might be. So in this case, 5-HT is an abbreviation for serotonin. So serotonin, again, kind of like dopamine, it's all over the body. It's in the GI tract. It's heavily used in mental health. We manipulate it there. All antidepressants, or the most common ones, are all serotonin manipulators. So anyway, you have serotonin here interacting with a receptor on a postsynaptic membrane. So let's say one neuron releases serotonin and says, I want you to talk to that other neuron. And if we have a good discussion, we're going to have positive mental health energy going back and forth, right? That's kind of how little smiley faces moving around in the brain. In actuality, right, it's way more complicated, but the basics are the same thing. So you have a molecule that gets released by one cell, produced and released by one cell, coming in and interacting with this receptor, and that receptor opens up. Now, let's give something that blocks that. So they're doing a very simplified way, but this is essentially how it works. You want your antagonist to look a lot like the endogenous product, but be slightly different enough so that it binds to the same spot, but it does so in a way that it confuses that channel so that it doesn't open. It's like, what is going on here? And at the same time, it blocks the actual serotonin from binding to it. However, you might have other spots too, so the serotonin could come in and bind to another site on the receptor. And you aren't going to be able to block every single receptor in the body, but you block enough of them, or you manipulate enough of them, that you get a therapeutic effect. And that's where dose adjustments come in, and scaling up and trying and titrating and things like that, where you eventually get to the point where you do block enough or agonize enough to get that clinical response. Yeah.
On that channel, if half of it's blocked by an antagonist, does that damage the effect of the channel at all?
Yeah, so the idea is it just closes it down completely.
Oh,
yeah.
Okay,
so you don't get a potential from there.
Even if serotonin bonds to that other site, it's still blocked.
Yes, it's possible that it could overcome that, and I don't know what the artist and what the artist's interpretation of this specifically was, but yeah, you could have theoretically a situation where you have different binding sites and things interacting, and yeah, you could have a partial opening or a more subtle effect, certainly, yeah.
Okay.
A little bit different, so moving on from receptors, but kind of the same concept as enzymatic inhibition. Sometimes we work with enzymes to manipulate the way that they interact with the body. So you can either give drugs that are basically an enzyme or a drug that modulates how the enzyme works. So a lot of our biologic agents are these big proteins that kind of mimic enzymes. But we have small molecule drugs that can interact with enzymes in the body and change the way that they can configure so that they can't bind to a receptor, or they bind to different receptors. So anyway, here's an example. You have a bacterial enzyme here, substrates bind to it, you get an enzymatic reaction, a bacterial enzyme, and an end product. Here what happens is you give a drug instead. The drug interacts with this substrate, they bind to the bacterial enzyme, and they shut it down from actually happening. So you've designed this drug to bind with this other substrate at a higher affinity or higher preference for it. Then when the bacterial enzyme picks it up, it still binds to it, but it can't do anything. And so you can do, like this would be an example of shutting down some bacterial defense mechanisms. For example, like, I'm trying to think of what I'm trying to talk about here. Beta-lactamase inhibitors, that's the word I'm looking for. So beta-lactam drugs, several bacteria out there produce enzymes that break down or have developed the ability over time to produce enzymes that break down drugs we give. So within the beta-lactam class, which are penicillins and cephalosporins and a lot of the major antibiotics we use, some of them, to make them more effective against certain bacterial species, we give them with a beta-lactamase inhibitor, which is something that's going to do this, and it's going to interfere with that bacteria's ability to produce the enzyme that's necessary to break down the drug. So ultimately shut down that bacterial's defense mechanism, then you can get your drug to the site of action on the bacterial cell wall more readily. So that's an example of how we might manipulate that. Kind of a similar process as far as the receptors. You think about it the same way. Your drug is interacting with something that's designed to do a specific job, and it's manipulating the way that happens, whether it's shutting that down or making that process different or accelerating that process. That just depends on the disease state. Again, competitive versus non-competitive antagonism, different binding sites. I think I already kind of talked about that, so I'm going to skip over the slide a little bit. You're not super important in the grand scheme of things, and when it comes down to clinical rationale for prescribing drugs, we don't really care all that much. Concentration and response, so time versus concentration. Usually your drugs are going to absorb and spend some time increasing once you take them. So if you take an oral medication, it's going to absorb slowly, and eventually you're going to hit a Cmax where it all gets absorbed. So if you're looking at drug monographs and you're like, this person took this medication at 8 a.m., when's the maximum effect? Well, you could say, well, maybe it's going to be at 2 hours after, because that's when the Cmax is, per the clinical studies. Now, this is just a general drawing, so it could be anything really. But this is how most drugs work, is they absorb, and then they have a somewhat linear decline as far as how they get eliminated from the body. So what we're looking at when we're trying to figure out how to dose a drug or how frequently to dose a drug is the duration of action. And that has to do with how long that area under the curve is above a certain threshold. So this is mean toxic. This is kind of a weird abbreviation here, but what they did here is did mean toxic concentration and mean efficacious toxic concentration. And the therapeutic range would be somewhere in there. So you want your peak to be somewhere in there. You don't want your peak to hit the toxic concentration. You don't really want to get too close to it in most cases because you don't want to cause side effects. So you get it up to somewhere in between. You get enough duration, and then maybe you'd give your second dose somewhere around here, and then you overlap your loop here, if that makes sense. So I don't know if I can draw on here. So maybe you give your next dose here. Something like that. It's not very good. But then you get more. So you want to minimize this. Probably isn't a good example. But over time, you decrease that gap there. And eventually, the concentration kind of gets higher and builds up a little bit more so that it becomes a steady state. And I'll show you a better example of that. My drawing here is really bad. But
where did you say MEC stands for?
I think they put mean effective concentration is what I would say it is. It's not really a real abbreviation. It's sort of like the minimum amount of drug you need in the system to cause an effect. Think about it that way. ED50 is a more common thing, which is the effective dose in 50% of the patient population. So ED50, and again, this is more of a logarithmic look at the same thing, but what you're looking at is the effective dose versus the TD50, which is the toxic dose, and then that margin of safety in between. That's where you're targeting your blood concentration. So you want to get steady state blood concentrations to live in that realm. So whether that's once a day, twice a day, or 3 times a day, or whatever you need to take the medication, that's how we dose and do frequencies of medications.
So what would MTC stand for?
That would be like the TD50, and MEC would be the ED50. Yeah, toxicity. And this LD50 is lethal dose of 50%. So unless you work in toxicology, that number probably doesn't mean a whole lot to you. But hopefully we aren't getting anywhere close to a lethal dose in 50% of our patients. Therapeutic index is what this graph is referring to as a margin of safety. And they calculate that by looking at the toxic dose in 50% of people divided by the effective dose in 50% of people. And that's where you get that thing. But they say margin of safety here, which might be more of an international term, I'm not sure. But therapeutic index is the common way we define that. So when I talk about drugs, I'll occasionally say it's got a wide therapeutic index, meaning that that baseline to get effectiveness from the drug is pretty low threshold. And to get toxic effects or side effects, it's pretty high. That's ideal. We want that wide therapeutic index. This gives us a lot of wiggle room to get the dose right. Narrow therapeutic index is tricky to work with, and there fortunately aren't as many drugs we use that are so narrow that we have to monitor. But a lot of times you have to do blood concentration monitoring to make sure that you aren't getting outside of those windows, because if you do, you could have serious side effects. Like digoxin is a good example. It decreases cardiac rate and has a lot of effects on the heart. It's very effective and appropriate within certain concentrations, but if you get a little bit above its therapeutic index, it can be really toxic really quickly. So that's one we do monitor for, at least when we start therapy. Yeah. Yeah, so anticoagulants are another thing. That's a little bit different just because anticoagulants are so dangerous to begin with because of increased bleeding risk. So but the newer anticoagulants, we don't actually monitor those at all. So it depends on how predictable the kinetics are. So with warfarin or Coumadin, the interesting thing about it is that it lasts for like a day or two in the body. And how people metabolize it and how it gets ramped up or how long they process it is really different individual to individual. So we have to monitor it because there's no consistent standard as to how people process it. Whereas with some of the new anticoagulants, they actually have pretty predictable kinetics. So we know that if you took it 12 hours ago, it's probably almost out of your system at this point. So that's a big factor in it too, as to how predictable the actual kinetics of the medication are, which we'll get to the kinetics here in a second. Okay, so generally speaking, if you increase the dose of a medication, you're going to increase the concentration, you're going to increase the pharmacologic response, and you're going to increase side effects too. So they all kind of go hand in hand. Now the idea is to find this medium here where you're getting that pharmacologic response without increasing the side effects to a point where they're intolerable. Sometimes if you start somebody on a medication, they'll get side effects immediately, and their body adjusts a little bit. Over time, those will wane down. It depends how severe and how debilitating they are. Obviously, we want to take safety as a primary concern when we're prescribing medications, but if somebody gets a little bit of dry mouth right away, they might get used to it after taking it for a couple weeks. Or if they feel tired or sleepy, that might go away as well. Again, I had a professor who always said, double the dose, double the concentration. It's a pretty good way to think about drugs. If you're going to increase the concentration in somebody, it's usually pretty linear. So if you increase your dose, you should jump that concentration up by twofold. Now, there are some things that have different kinetic profiles. Some are exponential, and we'll talk about that here in a second. Vancomycin is a good example. It's an antibiotic that we'll talk about in more detail in the recorded lecture, and we'll bring it up next week too. But it's one thing that we dose very specifically based on blood concentrations. It's renally eliminated, and we really target a very tight window to make sure we're getting enough drug in the body to kill bacteria and not enough to cause people ototoxicity and renal toxicity, which are its two side effects. And so we monitor it regularly. It's kind of was clinical pharmacy's bread and butter back in the 70s. People started saying, hey, let's monitor this and look at blood values and see if we can get good examples of improved cases and see what we really need to target to safely prescribe this medication. And so it's something that came about where we actually do very specific levels and titrations of that. But the point is still the same, and it's a pretty linear drug. You give more, double your medication, you're probably going to get double the blood level or something pretty similar to that. Nonlinear kinetics, like this PHT here stands for phenytoin. That's an anti-epileptic drug. So if you give this medication, it's kind of got a linear response for the first phase, and then it really increases exponentially. The problem is that exponential increase is right in the therapeutic window. So that's a medication we do monitor pretty closely if people are on it. It's not as popular of an anti-epileptic as it used to be. It's an older medication, but it is one example that is a nonlinear. Sometimes drugs act like this because of, well, a lot of reasons. They can use up their capacity to be metabolized. Sometimes they might be highly protein bound, so they're bound to albumin in the blood. And if somebody's malnourished or if somebody's used up their binding sites on albumin, you can have a lot of free levels increase. And we'll talk about some more of that here in a few slides. Half-life and steady state. So your half-life is the time it takes the drug to lose 1/2 of its maximum concentration. And so with each half-life you go down, you lose about 1/2 of what's left in the blood. So generally speaking, after 3 half-lives, that's like, what, 87.5% of the medication's gone. That's probably enough to no longer have clinically relevant amounts of drug in the body. Now, it does depend on what the half-life is. If your half-life is 6 days, it's going to take a lot longer to get there, right, than if your half-life is 6 hours, where the drug's going to eliminate pretty quickly. Steady state is the rising rate in versus the rate of the drug in versus the rate of drug out. That's what I was trying to draw originally. So the idea is once you take your first dose, you start to eliminate it, and you cut off that elimination point, take your next dose, and eventually you reach a point where your body's kind of reached equilibrium with how much you're taking in and how much it's metabolizing. And that usually takes 5 half-lives, or if you want to cheat, 3. So if you look at 3 half-lives here, this is the time in half-lives, 1, 2, 3. That's pretty much, it's a little bit under your steady state concentration. If we go up to 5, you're kind of right at that. And granted, this is a drawing. But the point is that we take a lot of consideration in half-life, and you're wondering how long that effect's going to last and how much time you have. If your patient missed a dose, what are we looking at? A lot of that depends on the half-life of the medication. Short-acting, long-acting. So I'll come back to that a lot throughout the course, talk about half-life. So as far as conceptually, like, this drug's got a long half-life, so if somebody misses it and they maybe are notorious for missing a dose or less compliant, a long half-life drug might be preferred over something with a shorter half-life. All right, switching gears to kinetics here. So this is what the body does to drugs. Basics of kinetics, and the 4 things we're going to go through are absorption, distribution, metabolism, and excretion. Start with absorption. Drugs have to get into the body to work, right? We can't just look at them and absorb them through our minds, unfortunately. So going to vary greatly depending on the dosage form is what things absorb, and even within dosage forms. So example, like some oral medications are like almost 100% bioavailable, where they absorb their whole dose into the bloodstream. Other ones are maybe 5% bioavailable. We've got tons of ways to put drugs into people, oral being the most common, IV probably the second most, lots of inhaled things, patches, aka transdermal, topical applications, meaning we aren't trying to get it into the body, but we're trying to treat the skin itself. Underneath the tongue, so sublingual or buccal absorption. Otic products, subcutaneous, ophthalmic, suppositories, intramuscular. Here's Obama getting his flu shot. And yeah, so you've got a whole spectrum of ways to put medications into people. Bioavailability means how much gets into the body compared to IV. So if you give somebody an IV dose of 10 milligrams of something, 10 milligrams of that drug just got directly into their bloodstream. You aren't losing any. Every other way, you're probably going to lose something via either it's staying in the tissues, or it's getting metabolized by certain enzymes that live in tissues, or it's going through other processes like going to the liver first or anything like that. The liver is your powerhouse for enzymatic activity, which we'll come to here in a second. But if you look at the differences here, generally speaking, if you give something IV, IM, sub-Q, or transdermal, you're going to absorb the vast majority of that product. Now, transdermal is a little tricky because only certain medications are packaged that way. There's not a ton of transdermal out there. And some medications just would not work transdermally. But the ones that are there do have pretty good bioavailability. Oral, again, varies significantly, and that's where dosing comes into play. So during clinical trials, if you know that drug doesn't absorb very well, you give enough to make sure you get whatever's in there. So you might give 100 milligrams of drug, only 5 actually gets in, but that 5 is enough to create a therapeutic effect because the drug's fairly potent. One thing we have is something called first-pass metabolism, which I'll talk about in a second, which is when you absorb something orally, it goes to the liver right away. Sometimes the liver will metabolize a chunk of that medication immediately. And if some drugs struggle with that, if they get metabolized too aggressively via the liver immediately before it gets into systemic circulation, you can bypass that. And rectal routes, sublingual and buccal routes also tend to absorb or tend to avoid the first-pass metabolism. All right, so first-pass metabolism, the dose goes into the GI tract. So here's your GI tract here. Some of it usually gets excreted unchanged in the feces. Most of it, well, depending on the drug, a lot of it might be absorbed, a lot of it might be excreted unchanged. It doesn't really matter for the purposes of this conversation, but some of it's going to get excreted out. The rest is going to go through the gut wall. The gut wall has some enzymes in it that can metabolize drugs. Then it's going to go to the portal vein, which is going to go right to the liver. The liver, again, being our powerhouse for enzymatic drug metabolism, is going to shoot out a whole bunch of it right from there. It's going to change it. It doesn't shoot it out. It changes it into a way that allows it to be excreted in the kidneys, which we'll talk about here in a second. And ultimately, you end up with some drug getting through all these systems and getting into systemic circulation unchanged to be able to go to the site of action. And that's what bioavailability is from an oral perspective. Remember, all our other methods basically avoid this. So when we're giving oral drugs, first pass metabolism does come into play as something that's important, something we need to think about. And I'll come back to an example of an interesting way we can manipulate that as well here in a second. Distribution, I don't really care about distribution a whole lot. Drugs distribute in the body. It's interesting from a science perspective, but from a clinical perspective, I don't know. It's not the most interesting topic we're going to talk about today. Basically, amount of drug in the body over blood concentration gives you your volume of distribution. Drugs distribute with their concentration gradient. So whether they're in the blood, total body water, extracellular, lymphatic, cerebral spinal fluids. I don't think I have fatty tissues on there, but that would be something too. So something to consider is like if a drug is bound to plasma or muscle proteins, would change its distribution. If something is lipophilic, talk about drugs that are lipophilic. Those can have different kinetics, or they'll distribute out into the fatty tissues, and then they can maybe slowly distribute back in as their concentration gradient changes. Some things that are lipophilic, the blood-brain barrier that separates the central nervous system from the rest of the body is very tight. It's hard to get drugs through there. If they're lipophilic, they can move through the fatty barriers of our cells really easily. If they're hydrophilic, or lipophobic, I should say, they might need special protein or special transport systems to actually get through the blood-brain barrier. So that comes into play if you're trying to treat like meningitis or acute pain. You can't put something in the brain to modulate how the brain's perceiving pain if it doesn't cross the blood-brain barrier. So most drugs, fortunately, do what they need to do. But again, we don't really care a ton about this because we're going to talk about where they're used, but at the end of the day, it's worth knowing just a little bit about how drugs move around the body. Protein binding, some things to consider. Again, there are a few drugs out there that are heavily protein bound, and where that comes into play are people who have maybe low muscle mass, or I think of elderly patient populations, also malnourished people, anorexic patients maybe, cachectic patients, or people who have cancer, HIV maybe, who are just really underweight or malnourished. Obese patients have a higher V, so they might have a increased amount of drug that's needed to get to that point if they are using a lipophilic drug. If they're using a hydrophilic drug, probably the same as a normal non-obese person who doesn't have the extra fatty tissue. Fluid accumulation, edema, ascites, pleural effusion, all going to have higher volume of distribution for hydrophilic drugs. Again, just something as a background for how drugs are dosed and how we consider drugs. I talked about the blood-brain barrier already. This shows a bunch of different transport processes. I don't care that you know any of this other than what I already talked about. So it's hard to get drugs across the blood-brain barrier. Lipophilic drugs can move over pretty much unchanged without any consideration by the body at all. Other ones have to use these odd transporter systems. So you'd have to design a drug to interact with one of these things to move across the blood-brain barrier that way. Metabolism. So very critical in selecting a pharmacologic agent. So basically biochemical processing of your drugs and transformation of them into something that can be excreted. So your body has all these processes in place designed to remove things that aren't endogenous. So if you ingest something and it's like a chemical or a drug or whatever it might be, your liver is going to take care of it for the most part. Not all drugs are metabolized. Some might just get excreted in the kidneys unchanged. Some might be eliminated via different pathways as well. But the goal is to get that product ready for elimination. All tissues have some ability to metabolize slightly, but we're going to focus on the liver as the major player. I listed some other ones there too. First pass, we talked about that. What else can happen is as drugs and drug byproducts get excreted back into the GI tract, some will get excreted into the bile and re-released. Well, the GI tract might reabsorb those, or there might be GI flora that modulate those medications after they've been. So it's like the liver went through all this work of converting that medication into something, getting rid of it. It went into the GI tract, and then some bacteria changed the way it works, and then it goes right back in and gets reabsorbed. So some drugs, like a good example of these would be oral contraceptives, are all enterohepatically recycled. So we actually rely on that mechanism to extend their half-life, because by themselves, without that, they wouldn't last long enough to be therapeutic. There's a number of other ones like that too. All right, let's talk about the liver. So this is a really important concept for the course in general, and so I recommend just thinking about it a little bit and going over it somewhat. But hepatic enzymes are a big role in drug metabolism, as I've said a couple times already. So what we're talking about here is something called the cytochrome P450 system, or CYP enzyme. So all the cytochrome P450 enzymes have like a CYP prefix, CYP, and then a number and a letter combination. So like CYP3A4, CYP2D6, stuff like that. I don't care that you know the individual CYPs, I just care that you know what the process is. CYPs metabolize via oxidation reduction reactions, and then other hepatic enzymes conjugate. So there's usually two-phase metabolism. So your drug gets into the liver, it gets oxidated, it goes through a redox reaction via the CYP enzyme. So that's the bulk of metabolism. And then usually it gets conjugated or glucuronidated or something in phase 2, where they're attaching something to it. And the idea is you're making the drug polar to enough degree where it filters through the kidneys and gets excreted out in the urine. That's the way the majority of drugs pass through the system. So for your oxidation reduction, you have your CYP enzymes here. The only reason, again, I told you don't need to know this, and you don't, but when I talk about CYP enzymes throughout the course, I might say, oh, this drug is CYP3A4 metabolized. That should be a little bit of a flag. That's a really common pathway. And so if a drug gets metabolized by that pathway or inhibits that pathway, when we have drug interactions, a lot of drugs interfere with these processes too. So they might induce it, meaning they ramp up the liver's ability to produce that enzyme, or they block that enzyme from happening, or they compete for it. Let's say you're taking 4 different drugs or whatever it is, and they all get metabolized by CYP3A4. Their body doesn't have enough to go around. So all those drugs are going to increase in concentration a little bit. So the whole concept of this is you've got phase 1, modulating the medication, changing the structure slightly. Phase 2, sometimes it will go to that to get further modulated, and eventually it's going to get excreted out in the kidneys. Here's an example, and again, I don't like to show structures a lot, and I will absolutely never test you on a structure, but you know, we're talking about the chemistry, so let's do it. This is codeine and morphine. So codeine actually gets metabolized into morphine. So when you take codeine orally, codeine goes to the liver, it gets metabolized via CYP2D6 into morphine at a very slow rate. Now some other codeine gets metabolized to norcodeine, which gets pretty much eliminated immediately or glucuronidated into a different metabolite and gets thrown out of the body. So codeine goes to morphine at about a 1 to 10 ratio. So I think codeine like a tenth of the percentage, 10% the potency of morphine. Morphine then gets glucuronidated into different metabolites as well. Some of those are active. Some of those actually will interact with the same receptors. Some of them will get eliminated, and over time it decreases itself. But it's kind of an interesting way to show that we have a drug called codeine, gets metabolized into a drug everyone probably knows as morphine. And you know, it's just the liver working that way, and the drug's designed to do that. Tylenol or acetaminophen has actually kind of an interesting metabolic pathway. Super common, everyone takes Tylenol at some point in their life. Tylenol works through a couple different metabolic pathways. Again, you got P450 pathways here. You've got a P450 or prostaglandin H synthase. I don't care you know that. But anyway, the P450 is going to modulate Tylenol or acetaminophen into a couple different products. There's this one mediator called NAPQI or NAPQI, which is then metabolized by glucuronidation and ultimately excreted. What happens is if you take a ton of Tylenol, you burn up the body's ability to do this, and it goes through a shunting pathway to a different CYP pathway when your glutathione gets depleted. And you end up with this other intermediary that the body's trying to figure out a way to process this molecule to get it out of the body, and ultimately it ends up causing toxicity to its own metabolic process. So you get a hepatotoxic intermediary there because you've taken too much Tylenol and you've used up all the enzymes. So we'll talk about Tylenol overdoses a little bit, but it's kind of an interesting illustration on how the body metabolizes drugs and how we do have a finite supply of these things. So you can use them up, and it does have problematic consequences. A prodrug is a drug that is metabolized by the liver and then into the active form. Excuse me. So what you have is a medication that is taken, so this is an example of clopidogrel, which is an antiplatelet agent. In and of itself, clopidogrel does nothing. It goes through the body. It gets metabolized via first pass. So it goes through that first pass metabolism process and gets metabolized into ultimately the active metabolite after a two-phase, one oxidation reduction and two, it's a two-phase oxidation reduction, excuse me. So anyway, the point is it goes through the liver, becomes active before it gets to the blood. So sometimes in drugs like that, we might actually use that process to our advantage to know that the liver will add these molecules to this drug and then make it active in that case. It's kind of cool science behind it. How people think of this stuff, I have absolutely no idea, but it's interesting. Again, we don't really care too much. It's a pro-drug. We care that it works. But at the same time, if you have somebody with liver failure or with an enzymatic deficiency, like some ethnic groups have poor enzymatic efficiencies than other ones, and some have increases and some have decreases. It's kind of generalized, but it tends to be a trend. But the point is that some people might not metabolize those prodrugs into the correct form, and they might not get the therapeutic benefit of clopidogrel. And so that's actually one of the cases where genetic testing really comes into play, and they actually do genetic testing for people on clopidogrel, which is brand name Plavix, before they start them on it, just to make sure that they can process that into the prodrug. Because if they can't, they could get another heart attack, and then they're back in the cath lab or back in your ICU. All right, so I mentioned these two terms earlier. Certain drugs induce the CYP system and certain drugs inhibit. So whenever I talk about drug interactions, I'm usually talking about these two concepts. There aren't a lot of inducers on the market. There just aren't. There's like maybe 5 or 6 of them that are relevant. So I'll mention them. And they're really rare. Like rifampin isn't used very often. It's kind of got some niche anti-infectious indications. Carbamazepine is an older medication as an anti-epileptic. Phenytoin, we talked about that already. It's another older anti-epileptic. There are a lot of inhibitors on the market, though, and I'll talk about those as we get through the course. So again, there's lots of examples of them, and those will decrease enzymatic activity. So if you're inhibiting the enzyme from working, you're preventing certain drug classes from getting metabolized, which means that your drug classes that you take that would normally undergo those pathways are going to become higher concentrations in the blood because they don't have that enzyme to break them down. Does that concept make sense? It's a really important one. Okay, so drugs with shared metabolic pathways, I talked about this. The competition is important. Some drugs don't do anything, but again, they're both using that same pathway, and they're going to increase each other. And usually that doesn't matter, but sometimes it might cause some side effects. Usually we try and avoid strong inhibitors or inducers, especially with certain disease states. Like a great example would be transplant medications, people on anti-rejection therapy. Those levels need to be very carefully controlled, and if they get out of whack, they can either cause pretty significant toxicity, or worst case scenario, you get organ rejection because the medication is not as effective as it should be. All right, a couple slides left, bear with me. Metabolic considerations, some things we think about, large individual variants. So this is not something we can generally predict. And again, this is kind of where genomics is pushing us more so to be able to test people's enzymatic activity and be able to map them with drugs that work with that profile. We aren't there yet, but I think we're getting closer. There are ultra metabolizers and poor metabolizers. When I was in school, we did this lab, and for example, people with Southeast Asian descent tend to be poor metabolizers, and certain enzymes that people of Caucasian descent tend to be ultra metabolizers on. And there's some reverse roles there too. So it just depends. Genetics have a big role in it as well, but that's not an absolute either. Diet and environmental. Certain things can increase enzymatic activity. Grapefruit juice can increase enzymatic activity. Cigarette smoking can actually increase enzymatic activity for some reason. Industrial exposure, again, we don't really care a lot about that. Age, elderly, neonates are going to be slow metabolizers. Adolescents, young adults are going to be the faster metabolizers. That probably is pretty common sense there. Androgenic hormones also tend to be linked to higher metabolism. So young men tend to metabolize faster than women of similar age. And disease states, so hepatic, cardiac, pulmonary, thyroid, inflammatory disease can all have effects on metabolism. We don't really care much about a lot of this. So again, there's a couple drugs that we do genetic testing for, Plavix being one of them. Most of this other stuff we work with. If your patient's taking something that's interfered with by grapefruit juice, tell them not to drink as much grapefruit juice a day. It's easy. So there's some ways we can get around this stuff. And other times, maybe your patient, drinks a gallon of grapefruit juice a day, and you're like, all right, I'll just figure it out and dose adjust it appropriately. You can usually get around a lot of these things if you just change the dose of the medication. So most of this doesn't matter. We don't really care a lot about age. We do dose adjust for kids and neonates. A lot of that's weight-based, though. It's not necessarily because, well, some of it's because of their metabolism. but more of it's because of their weight and being smaller people. So anyway. All right, final couple slides. Excretion. The kidneys are the major players here and excrete drugs and metabolites for the urine. So remember, our whole concept here, liver modifies drug, kidneys excrete drug. That's pretty much it. We measure kidney function a couple ways, glomerular filtration rate, or GFR, and creatinine clearance. They're two different equations and two different terms. They measure the same thing, and that's kidney function in milliliters per minute. So there's two different equations. One's called the Cockcroft-Gault, which is here in blue, and it's an easy equation to use. You could do this with virtually no information on the patient. You could do this with a handheld calculator on your phone pretty easily. The MDRD, or the GFR equation, it has a bunch of odd variables associated with it. You'll notice a couple things. There's multipliers. So overall creatinine clearance for women is going to be lower than men. So creatinine, have you guys talked about creatinine at all? It's a biomarker, muscle production, right? So men just having higher muscle mass than women, generally, we compensate for that. Same thing with the GFR equation, has the female compensation here. It also has, for people of African or Caribbean descent, tend to have higher muscle mass than people of Asian or Caucasian descent. So there's a compensation factor there as well to increase their GFR slightly. So we're looking at serum creatinine as a biomarker for how the kidneys are filtering things out. So if the kidneys aren't functioning, they aren't going to process creatinine, so your creatinine's going to elevate. So that's what we use this for. And so it's all related to creatinine, age, weight. That's pretty much it. And then, of course, there's other factors. So you might imagine that this gets manipulated a little bit. Let's say you have a really old patient, like a 92-year-old who looks healthy and is doing great. Maybe they're like 50 kilos, though, so they also don't weigh a whole lot. And their serum creatinine looks perfect, though. They've got great kidneys for their age. That's, the serum creatinine is 0.8. Which is a great number. So they're still going to calculate quite low just because of their age and their body weight. Does that mean their kidneys are non-functional? No, they probably are doing okay. So you do have to take some of those skewing factors into the equation. Another thing to consider is if you work with patients who have maybe amputees, people who are missing limbs, their weight's going to be a lot lower. It doesn't mean their kidney function's worse off because they don't have as much muscle mass or as much creatinine production. So there's things to think about with that perspective as well. The big difference between these equations and why I bring them up as different is a lot of people refer to the GFR as sort of a blanket term. Oh, the GFR is this or that or whatever. Drugs are all dosed, and we're all dosed for a long period of time based off the Cockcroft-Gault equation. So when we dose somebody, if we're going to dose reduce them to say, well, this drug is heavily excreted by the kidneys, we can't give you the full dose because your kidney function is like half of a normal person's. We use the Cockcroft-Gault equation to calculate that. That's because pretty much every drug out there has done that. Now, Cockcroft-Gault equation has a bunch of issues with it, and there's a lot of studies that say it's not ideal, but that's what the drugs were studied on, so that's what we use. The MDRD equation is the newer one that's more takes more factors into consideration. It's probably more detailed. It's used for CKD staging, and it will give you some drug dosing. That's newer drugs are coming out with updates on using the MDRD equation and the GFR as opposed to the creatinine clearance. So the point is that they're slightly different in how we use them. They ultimately are very similar numbers, but they could be kind of different if you calculate different variables with them. So just so you know, you might see something on your computer or in your electronic medical record that says GFR, and you might call the pharmacist and say, well, why'd you dose reduce this? The GFR is 65. I'm like, well, the creatinine clearance is calculating at 50, so that's per policy I dose reduce that medication. So you might see those subtle differences actually come into play. So anyway, it's not something you have to deal with a lot, or that even I have to deal with. As far as the calculation, this is all done on computers. There's lots of apps that do this for you, so certainly use those. But at the end of the day, do know that drugs are dosed just based on this. If a patient has kidney compromise, you will use these equations to figure out how to dose reduce certain medications. Creatinine alone is not a measure of renal function, right? You can look at somebody's creatinine, it's not the whole picture of what you're seeing. So you have to use one of the equations to really get that perspective. And finally, one of the things pharmacists are trained on pretty heavily is pharmacokinetics and doing dose adjustments and understanding renal function and hepatic metabolism. It's complicated. It's really important to know. But at the same time, lean on your friends and know that there are people in the medical profession that have studied this more extensively than this one lecture you guys will get. So that's all I've got to say for today.